You'll have time to read the questions before you hear each extract, and you'll hear each extract once only. Complete your answers as you listen. At the end of the test, you'll have 2 minutes to check your answers. Part A. In this part of the test, you'll hear 2 different extracts. In each extract, a health professional is talking to a patient. For questions 1 to 24, complete the notes with information you hear. Now look at the notes for extract 1. Extract 1. Questions 1 to 12. For questions 1 to 12, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
Hello, Doctor. Good morning.
Yes, good morning. What's your problem?
Well, Doctor, I have a sinus problem. I get postnasal drainage, facial pain, headaches, sore throat and congestion.
Since how many days have you been facing this problem?
For the past 2 weeks, Doctor. I'm also getting snoring, teeth pain and nasal burning.
Is it moderate or severe?
It worsens in the evening and morning.
What's your age?
47, Doctor.
Did you have any illness previously or any surgeries?
Yes, surgeries, gallbladder and hernia.
Do you drink, smoke?
I don't drink, but I smoke 1 pack of cigarettes per day for the past 15 years.
Any of your family members have any illness?
Yes, I have a family history of allergies and hypertension.
What are the medications you are taking?
Claritin, Dilantin and Rhinocort nasal spray.
Are you allergic to any medicine?
No, Doctor.
Well, your auricle's external auditory canals reveal no significant abnormalities bilaterally. TM's intact with no middle ear effusion and are mobile to insufflation. Your intranasal exam reveals moderate congestion and purulent mucus. Your orophonics examination shows teeth, alveolar ridges reveal missing molar. Examination of the posterior pharynx show a prominent uvulva and prominent postnasal drainage. The palatine tonsils are 2+ and cryptic. The palpation of anterior neck reveals no tenderness. Examination of the posterior neck shows mild tenderness to palpation of the suboccipital muscles. Facial examination shows there is bilateral maxillary sinus tenderness to palpation. Waters View X-ray reveals bilateral maxillary mucosal thickening. You have acute maxillary sinusitis, 461.0. Snoring, 786.09. Well, I am prescribing you Augmentin, 875 milligrams twice a day, and Mucofen, 800 milligrams twice a day. Follow these medications for 3 weeks and meet me after that. If the conditions don't improve, then I will order a mini sinus CT.
Extract 2. Questions 13 to 24.
Hello, doctor. Good morning.
Good morning. What's your problem?
Well, I have a headache and pulsatile tinnitus. For the past 3 months, I've been getting severe headaches, and almost daily. I'm getting pulsations in the head with heartbeat sounds.
Exactly at which point of your head do you feel pain?
On top of my head.
Are you getting nausea or vomiting associated with the headaches?
No, doctor.
Is there any previous history of headaches?
No, doctor. But apart from last 3 months.
What's your age?
44, doctor. When I speak on the phone, I get weird sounds in my left ear. I get pulsating sounds only in left ear.
When did this problem start, actually?
Well, actually, the ear pulsations began following a flight trip to my native place.
Is there any drop or change in hearing?
No, doctor. But I had dizzy episodes in the past with nausea being imbalanced at times.
Is there any change in your vision?
No, doctor.
Well, do you smoke or drink?
I do not consume alcohol, but I used to smoke 1 pack a day, and now I have completely stopped it.
Have you had any previous illness or surgeries?
I had skin cancer on my arm and back. I am a kidney donor, so I had a left nephrectomy, C-sections, mastoidectomy, laparoscopy, and temporal arteritis.
What medications are you taking?
Tylenol, Excedrin, and a multivitamin and probiotic.
Are you allergic to any medicine?
Yes, to codeine and penicillin.
Tell me your family history of illness.
Well, my father has a cancer, hypertension, and heart disease.
Your physical examination shows your blood pressure at 120/78, pulse 64 and regular, and the temperature is 97.4. Cardiovascular test shows regular heart rate and rhythm without murmur. There is an old mastoidectomy scar on your left ear. Weber exam is midline. Grossly hearing is intact. You have pulsatile tinnitus. Left ear with eustachian tube disorder as the etiology. There's also a possibility of normal pressure hydrocephalus, deviated naval septum, dizziness, probably due to possible Meniere disease. I would recommend you to start a 2-gram less sodium diet. I am ordering a carotid ultrasound study as part of the workup and evaluation. Since your disease is related to eustachian tube, I'm prescribing Nasacort AQ nasal spray, 1 spray each nostril daily. You use the hearing protection devices at all times. I will recheck you in 3 weeks. If the pulsatile tinnitus does not improve, then I would recommend other treatments, including myringotomy or ear tube placement. You have to undergo for an audio and tympanogram prior to the treatment procedure.
That is the end of Part A. Now look at Part B. Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B or C which fits best according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen. Now look at question 25. Question 25. You hear a trainee doctor discussing a patient diagnosis with a tutor. Now read the question.
Let's have a quick chat about the diagnosis for Janine in Ward 2.
Yeah, I was a bit unsure about that one. because it's a young patient, it's not going to be diverticulitis, or...
Well, it's possible, but she is young, so yeah, it's unlikely. So, what do you think? What else could it be? What else happens in the bowel? Something common. Think about common things.
Bilateral lower abdominal pain? Because it's like radiating into the back?
Yeah, something very much more common than that.
Gastroenterological?
Yeah?
I can't think.
Possibly related to diet?
Celiac disease?
Perhaps, but there's not a lot of other symptoms pointing to that. What else would give you discomfort in the bowel? Lower abdominal pain.
I suppose if they're just constipated.
Right, yeah, constipation.
Question 26. You hear a discussion between two doctors on adjuvants used in vaccines. Now read the question.
Doctor, what is an adjuvant and why are adjuvants added to vaccines? Well, an adjuvant is used in vaccines to create a stronger immune response in patients. Certain vaccines made from dead or weakened germs contain naturally obtained adjuvants and help the human body produce a strong protective immune response. These vaccines often must be made with adjuvants to ensure the body produces an immune response strong enough to protect the patient from the germ he or she is being vaccinated against. In the US, monophosphoryllipid A and aluminum are used as adjuvants in the vaccines. Monophosphoryllipid A has been used as an ingredient since 2009 in the vaccine called Cervarix. Aluminum salts or gels are used as ingredients in vaccines since 1930. However, most vaccines developed today include just small components of germs, such as their proteins, rather than the entire virus or bacteria.
Question 27. You hear a discussion about possible causes of arthritis. Now read the question.
Hello, Doctor. Can you tell me what are the possible causes of arthritis?
Osteoarthritis is associated with cartilage damage. Genetic conditions are thought to play a role in osteoarthritis. Age alone is no longer seen as the cause of osteoarthritis. Rheumatoid arthritis is an autoimmune disease that develops as the immune system malfunctions and attacks the body's own tissues. Gout develops when excessive uric acid accumulates in the body and crystals are deposited in the joints. Reactive arthritis causes joints to become inflamed as a result of an infection that triggers the immune system. Usually, this condition resolves.
Question 28. You hear the announcement of a new drug, Avastin, used in colon cancer treatment. Now read the question.
A milestone in cancer treatment. Cut, burn, and poison is the expression that describes the traditional 3 steps involved in the cancer treatment. Specifically, the expression means to cut out the growth of the cancer tumor, burn the carcinogenic cells with radiation, and poison those that remain with chemotherapy drugs. Interestingly, a young doctor from the US proposed another method to treat cancer about 30 years ago. He thought that abandoning the blood supply to cancer tumors could block their growth, but many scientists dismissed this concept for a long period. However, last month,
The Food and Drug Administration of the U.S. approved the drug called Avastin that works the way he proposed. Although the drug does not cure the cancer, it increases the lifespan of the patient with colon cancer. Avastin is a genetically engineered protein that connects with the protein in the human body that promotes the growth of the blood vessels. The protein, also known as vascular endothelial growth factor, intervenes with the supply of blood to cancer and starves the cancer cells. Avastin targets the weak places of cancer cells, though it does not damage normal tissue. Whereas chemotherapy kills cancer cells, and also the other normal cells resulting in infections along with stomach and intestinal problems. There are also other drugs being tested to investigate whether they can stop the formation of blood vessels. In the past 2 years, Avastin is one of 3 new drugs approved for colon cancer.
Question 29. You hear a trainee nurse asking his senior colleague about the use of anti-embolism socks for a patient. Now read the question.
I noticed that Mrs. Jones isn't wearing the usual anti-embolism socks, but I didn't want to ask her why not because she was asleep. Is it because her legs are swollen?
Well, sometimes we don't recommend the socks if there's severe swelling with edema, but that's not the case here. Mrs. Jones was actually given them initially on admission last night, but she told us this morning that her lower legs were feeling numb. She described it as having no feeling. Until we've checked out the reason for that, for example, it could be an underlying condition which could damage her arterial circulation. We're reducing the risk of thrombosis by pharmacological means.
Oh, I see.
Question 30. You hear a discussion between a doctor and a nurse on different stages of gout. Now read the question.
Hello, doctor. What are the different stages of gout?
Well, there are various stages through which gout progresses. In the asymptomatic hyperuricemia stage, the person will elevated uric acid levels without any outward symptoms. The acute gout stage occurs when the urate crystals suddenly cause inflammation and intense pain. This condition is also called flare that can be triggered by alcohol and drug usage, stressful events, and due to cold weather. The intercritical gout is the period further urate crystals are being deposited in tissue. The main difference between gout and pseudogout is that the joints are irritated by calcium phosphate crystals instead of urate crystals. Chronic tophaceous gout is the most debilitating stage. Permanent damage might have occurred in the kidneys and joints. The patient can also develop tophi, big lumps of urate crystals in joints of the fingers. Pseudogout is the condition that is confused with gout.
That is the end of Part B. Now look at Part C. Part C. In this part of the test, you'll hear 2 different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B, or C, which fits best according to what you hear. Complete your answers as you listen. Now look at Extract 1. Extract 1. Questions 31 to 36. You now have 90 seconds to read questions 31 to 36.
one of the lead researchers, Dr. Larry Apple, who specialises in testing diets.
Previously, we had done 3 major feeding studies. By feeding studies, I mean studies in which we provide everything that a person eats and drinks for a fairly long period of time. Some of our studies have lasted up to half a year. So our first study was DASH, Dietary Approaches to Stop Hypertension, that identified an overall dietary pattern that was helpful in terms of lowering blood pressure and cardiovascular risk. Then we did a study.
Which was a diet low in salt and high in fruit and vegetables.
Actually, it tested attributes of diet other than salt. So salt was held constant, but in the diet that was most effective was a diet that was rich in fruits and vegetables, low-fat dairy products, and reduced in saturated fat. Then we did a second study that addressed the issue you brought up, Norman, which was the effects of salt on blood pressure. In that, we did a dose-response study, and the lower the sodium intake, the lower the blood pressure. Then we did a third study where we said, okay, well, those diets, the DASH diet is relatively high in carbohydrate. What if we reduced some of the carbohydrate and replaced it with protein or unsaturated fat, mostly monounsaturated fat that you would get from like olive oil, for example? I'm looking for the optimal diet to lower blood pressure because blood pressure is such a powerful risk factor for heart disease and stroke. The diets that were higher in protein and higher in monounsaturated fat had slightly better reduction than the original DASH diet, but not so much that you would say we should change our guidelines. It basically said, if people reduce their saturated fat, they can replace it with carbohydrate, unsaturated fat, or protein, which is a good message, that gives people flexibility. Then our fourth study is the OMNI-CARB study. That was a study to look at the effects of glycemic index on cardiovascular risk factors. And so the idea was to say, okay, people have been espousing a low glycemic index diet is helpful. Typically, in terms of heart disease, what you see are signals related to LDL cholesterol, blood pressure. And to our surprise, there really were no major effects of the low glycemic index diets on risk factors for cardiovascular disease. So if you were a participant in our study, you would have been randomized to a sequence of 4 different diets. So one,
you were your own control because you went through all 4 diets
right,
yourself.
So you could compare your effects on one diet to your effects on the other diet. So here are the 4 diets. One is high carbohydrate, high glycemic index. That's what we said was our sort of control diet. Then high carbohydrate, low glycemic index. Those are carbohydrates that take a bit more time to get into the bloodstream and you avoid large fluctuations. Then the third diet was low carbohydrate, high glycemic index. And the fourth, and the one that we thought would be the best, would be low carbohydrate, low glycemic index. Okay? So we are really interested in the control versus that one. Now, each of those diets, by the way, were fed for 5 weeks. People consumed all 5 weeks of the diet, and then we measured very rigorously, the risk factors, lipids, blood pressure. We measured insulin resistance as well, and we really did not see any benefit from the diet that was low in glycemic index.
And wasn't there a bit of harm from one of the diets?
I was agnostic on this one. I wasn't quite sure what the direction of the results would go, but I thought that if anything, there would be a signal of benefit. And actually, there was a bit of a signal of harm. It was one of the diets that had the low glycemic index. LDL cholesterol seemed to go up, which is the form of cholesterol that is considered bad.
I think Frank Snacks argues that the categories of food around low glycemic index, it may well be the fiber in them that's the issue, not the...
Yeah. See, this is a common issue with studies of diet or food or nutrients, is that nutrients don't come in isolation. They're what they call confounding. Nutrients travel together. So typically, most foods that are high in glycemic index are low in fiber, and foods that are low in glycemic tend to be higher in fiber, sort of like the white rice versus brown rice or whole grain. So that's where we sort of think this is going, is that you can get the benefits that we attributed to low glycemic by focusing more on other aspects of diet.
Moving now to obesity, which you've done a lot of research into. You've tried behavioral change, you've tried feeding diets and so on. How would you sum up the state of the art from your research in terms of what you've found?
Doing feeding studies, it's one of my favorite forms of research because you get clean answers. Our participants...
It's not the real world.
It's not the real world, but it tells you what would happen if you consume this diet. What you get with behavioral intervention studies is, well, can you, in the real world, follow a diet? And so individuals have to deal with all of the things that you and I deal with.
So have you found in your research behavioural interventions which look promising?
I have done a fair amount of work on helping people who are overweight or obese try to control their weight, and you do get some benefit from various behavioral interventions.
Such as?
What we typically try to get individuals to do is to, first of all, know where their calories come from, so they actually do what they call food records. So some individuals, it might be sugar-sweetened beverages, other people, it might be large portion sizes, other people, it might be frequent eating across the day. And then what you do is, working with a counselor, you identify types of foods, episodes of calorie consumption where you can pull back and where you can make substitutes and do things that are feasible. The challenge is that in order to lose weight, you have to have pretty big calorie deficits. So people typically say in order to lose about a pound every other week, you need to reduce your calorie intake by 500 calories per day. To do that, you really need to track your weight, track your calories, and so we actually embed in most of our interventions now tools to help people self-monitor. The other thing that we do is we try to have some type of continued intervention, because weight loss interventions are not just something that just sort of you give it and it's over. It really requires some efficient way to sort of continue it with fairly frequent contact, but doing it efficiently. So instead of having a person either meet you or call you, you have some sort of inexpensive approach to sort of keep you engaged over time, which we think is really important.
And very quickly, a huge problem in Australia, which is damage to your kidneys, which can affect your health profoundly.
Yeah, that's another area of my interest. So I try to look for interventions that are modifiable. And so I've been interested in diet, physical activity. With kidney disease, it's probably a mixture of modifiable as well as genetic.
You accumulate this, it's aging, it's it's arterial disease, it's drugs, it's all sorts of things that accumulate kidney damage as you get older and increase your risk of heart attacks and strokes.
Aging represents the cumulative burden of exposures or bad things that have happened to us over time. So if we're consuming foods that damage, our arteries or kidneys over time, that'll progress. Now I don't want to dismiss the effects of diet. There have been other investigators who have focused on diets rich in fruits and vegetables, and there might be a benefit in terms of called acid-base balance, where we're providing some what we call bicarbonate, which is a base, that actually helps to preserve kidney function. It's early evidence. I think there's a good signal there. But there's something going on. I can tell you that just in this community around Hopkins, very high prevalence of chronic kidney disease, proteinuria, which is a manifestation of kidney disease. And many of us think that it's something about the environment, and I personally think it's an adverse diet that is actually contributing to it.
Extract 2, questions 37 to 42. You hear an interview with haematologist Christine Ford about blood donation. You now have 90 seconds to read questions 37 to 42.
Hello, my name is Dr. Christine Ford. I'm a hematologist on a mission to make giving blood more accessible to the masses. Blood donations and transfusions go hand in hand in most cases. Sufferers of certain conditions like thalassemia, sickle cell disease, and hemophilia, for example, require regular transfusions. In fact, the number of people in the world needing a blood transfusion is increasing. In most countries, blood donations are voluntarily made, and the number of charitable blood donors has increased to 112.5 million people over the years. According to the World Health Organization, most of the blood donated by voluntary donors is given to recipients who are 65 years and above. However, in low-income countries, 65% of the blood donated is transfused in children under the age of 5. The donation rates still vary in both the low-income and high-income countries, in that high-income countries account for 32.1 donations, upper-middle-income countries account for 14.9, while lower-middle-income countries account for 7.8. It's likely that this is the reason why, even though theoretically donating blood should be purely voluntary, some states do offer financial incentives to encourage people to donate. Blood is often extracted from an individual who volunteers after screening for certain diseases like HIV/AIDS, Ebola, and hepatitis virus, among others, has been completed. It can either be transfused as a whole, or some parts of it like the plasma, platelets, or white blood cells only. According to the National Health Survey, whilst the majority of people are allowed to donate blood in the U.S., the practice is regulated. One such regulator is the Advisory Committee of Safety of Blood, Tissues, and Organs, who released new rules regarding the treatment of donors in 2017. According to a national health survey in the United Kingdom, the number of daily blood donors needed to provide enough blood for the number of transfusions that occur daily is 6,000 donors per day. Annually, the number of new donors needed by blood donation centers is approximately 200,000 people. To date, the majority of blood donations are made by people over the age of 45, spurring multiple campaigns aimed at encouraging young people to participate. Blood donation does not depend on ethnic characteristics, although significant efforts are made to encourage ethnic minorities to increase their engagement with blood centers due to the significantly lower number of registered donors from diverse populations. So first, let's consider the characteristics of the ideal donor. The person must be fit, healthy, and free of viruses like HIV/AIDS or any type of cancer. Ideally, they would weigh between 7 and 25 stone and would be between 17 and 66 years of age. As an exception, previous donors can be aged up to and over 70 years old if they have given blood within the last 2 years. Assuming the aforementioned criteria is met, there is a preference for male donors over female donors, as their additional average body weight means that they are likely to have suitable iron levels. Furthermore, their platelet count is usually higher, and as such, they are on average able to give blood more frequently, every 12 weeks opposed to every 16 weeks for women. After a suitable donor is found, in order for a blood transfusion to take place, the blood must be screened, and it must be ensured that it is safe to use. The grouping and cross-matching of the donors and recipient's blood are also important prior steps. During the transfusion process, the recipient must be keenly monitored for any reactions to the blood being transfused. In addition, their vital signs like blood pressure, temperature, and pulse rate, among others, should be observed quarter-hourly and documented correctly throughout the whole transfusion process. Part of my mission to demystify the process of becoming a blood donor is speaking to people who have either given blood in the past or have given it serious consideration. Using an anonymous survey, I ask them why they decided to partake in this altruistic and life-saving act. I find that by anonymizing the results, we are able to elicit more candid responses, meaning that the reasons I hear are rather surprising. The majority of people cited reasons such as that the good it does far outweighs the slight discomfort during the procedure, or words to that effect. However, every now and then, I'd come across a story about a person who felt that they would have died if it wasn't for their donor and the stranger who made blood available to them. The new lease of life they now have has made them so grateful that they wish to pay the kindness forward to someone else. Regardless of the reasons they gave, it was rather surprising to find that not a single participant cited monetary reward.
That is the end of this listening test.